Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. One second. Yes, hi. Assalamu alaikum. Good evening. How is everyone? Welcome to tonight's series of webinar organized by the Emirates Clinical Nutrition Society. Our title for tonight is Cow Milk Allergy, organized by our sponsoring Nestle. This webinar is organized by the Emirates Clinical Nutrition Society, and I will be going through the society as a short. It is a non-profit society established in the year 2016 by the efforts of a group of clinical nutritionists, and the society serves to conduct continuing professional development activities, which enables nutritionists to update their knowledge and provide common platforms to network, aims to reform the lifestyle of communities in the United Arab Emirates in order to increase productivity, to promote healthy living. What do members benefit from joining the society? Information on medical meetings and conferences held locally and abroad, quarterly Emirates Medical Journal, which features research papers and case reports written by local and foreign doctors, reduced rates in participation in all Emirates Medical Association activities, organized workshops, seminars, and conferences. How to be a member? Either register through the EMA website or a direct email, membership@ema.ae, or you can directly contact us through the number that you see on the screen through Facebook, Instagram, and Twitter. And without further ado, just a few housekeeping rules. This webinar is live streamed on the MCI YouTube channel. And if you have any questions related to the webinar, please type them in the Q&A box, mention the speaker's name in the question along with the question. You can find that in the control panel below. If you have any questions, technical questions related to the webinar, directly WhatsApp the number that you see on the screen. And finally, this webinar is accredited by the Dubai Health Authority with 1.5 CME. So our first speaker for tonight is Dr. Fatma Al-Ulama, who will be speaking on the medical perspective on the management of cow milk protein allergy. Dr. Fatma is a consultant and head of child health section at Dubai Health Authority. She is the acting head of preventive promotive service program section since September 2012 and a leader of the early developmental screening platform or program in Dubai, leader in developing Dubai tool for developmental screening Bara'im, and is an associate professor in the MCG. Thank you very much, Dr. Fatma, for joining us tonight's webinar. The floor is all yours. You may start.
Assalamu alaikum wa rahmatullahi wa barakatuh. Many thanks, Dr. Alia, for your introduction. I would like to thank Emirates Clinical Nutrition Society for giving the chance to share this nice webinar today. I am going to talk to you regarding cow milk protein allergy. So I want to share my slides. So from the name, you will know that cow milk protein allergy is,
Can you share your screen, Dr. Fatma? It's not showing yet.
Yeah, I will share now. It's showing now?
No, not yet.
It was showing now because you can see now?
Yes, yes. Now it's okay. Just full screen mode and you are off to go.
Okay, thank you so much, Dr. Alia, for your nice presentation, introduction. And good afternoon, good evening, my colleagues. Really, it is a pleasure to be with you all in this evening. So as the name of the title, cow milk protein allergy, we know that this is an allergic condition which is triggered by drinking cow milk or by drinking or eating products made from cow's milk. So let us see what is the cow milk protein allergy. During my talk, I will tell you a little about introduction, epidemiology, clinical finding, natural history, diagnosis. And the management, I will leave to my colleague dietitian who will tell us in details. So cow milk allergy, cow milk's protein allergy, it is the most common food allergy in young children. And usually it presents with a wide range of clinical syndrome due to immunologic response to cow milk protein. It can be immunoglobulin IgE mediated, or it can be non-IgE mediated, or it can be mixed. So it is the most common food allergy in young children, but you can imagine approximately it is affecting only 2% of children under 2 years of age. So please, before labeling any child as having cow milk protein allergy, you have to think 100 times, because to diagnose, you can see the prevalence, or it is only 2%. But I can see in the clinical practice or in the real life, most of the children unfortunately labeled as a cow milk protein allergy. So it is the third most common food allergy after peanut and tree nuts. So clinical findings frequently appear during the first few months of life, often within days or weeks after the introduction of a cow milk-based formula into the diet. It may also occur with exclusively breastfeeding if cow milk protein from the maternal diet is transmitted in breast milk in sufficient quantities. So no need, please, 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 because what I see in the clinic every day, the child, why the mom, you are not breastfeeding your child? She said, because my child was having diarrhea. I went to the doctor, my private doctor, and they told me your child have a cow milk protein allergy, and I stopped it. The other mom is telling me, my child, I am asking, why you are not breastfeeding your child? She said, I was breastfeeding my child, but my baby was having abdominal distension. And then the doctor told me your child have cow milk protein allergy. And really, this is daily. Another baby, she will tell me my baby is passing motion whenever I am feeding. So the doctor did the stool test and diagnosed as a cow milk protein allergy. So it is really common practice and very easy to say to the mom that your baby has cow milk protein allergy and stop your milk. It is easy for us as a word, but to tell a mom and to stop the best formula, the best milk, which the God is created for the baby, which is different in the morning composition, will be different, in the night is different. When the baby is 1 day is different, when the baby is 2 days, yeah, you cannot imagine what is this milk which the God is created. Please, before you label your baby, your clients, your patient, anybody in front of you as a cow milk protein allergy, you have to think 100 times, not only one time. So patients with cow milk protein allergy present with a wide range of IgE and non-IgE mediated clinical syndrome. So if it was clinical finding, when you will say it is IgE mediated reaction, when it occurs immediately, within minutes of 2 hours after ingestion, if you found there is any sign, any symptoms develop the child, you can label them as IgE mediated reaction. They can present with skin rashes, with eczema, atopic eczema. They may have oropharyngeal edema. They may have upper and lower respiratory tract symptoms like stridor. They may present with breathing difficulty. They may present with a cough. They may have gastrointestinal symptoms in the form of vomiting, loose motion. They may present as a cardiovascular signs and symptoms. They may collapse. They may have anaphylactic reaction. So it is there, but not is that common that what we see every day. The clinical finding which tell you it is not is it mixed or it is non-IgA mediated reaction. They can present the mixed reaction may have either humoral or cell-mediated mechanism and may present with acute or chronic. So when it is the symptoms is acute or chronic, you can say it is mixed IgE plus non-IgE mediated symptoms. So let us see the clinical finding when they present with mixed IgE and non-IgE mediated. Atopic dermatitis. Atopic dermatitis is so common in our country. Maybe due to our humidity, there are so many causes before you label the child as this eczema or atopic dermatitis or this rash due to cow milk protein allergy. One of the presentation can be eczema, but not every child with a rash, not every baby coming to you. Please take a time 5 minutes, 2 seconds, or I don't know, whatever time you have to take more history. So milk is the second most common allergen reported in infants and young children with moderate to severe atopic dermatitis. But there are lots of causes that the baby or infant can present with atopic dermatitis, not only cow milk protein allergy. So the other clinical findings, which say mixed IgE and non-IgE mediated reaction, it can be allergic eosinophilic gastrointestinal disorder. Okay. They can present this as esophagitis. It is a disorder characterized by eosinophilic inflammation of the esophagus. The patient with these disorders have a symptom suggestive of gastroesophageal reflux, and they are unresponsive to conventional reflux therapy. So it doesn't mean that any baby presenting to us with gastroesophageal, for example, for vomiting, we have to label the baby as a cow milk protein allergy. No, it can be one of the presentation gastroesophageal reflux, but there are hundreds causes of the gastroesophageal reflux. Their presentation is different. So please don't put in your mind the first diagnosis of gastroesophageal reflux, it is cow milk protein. It can be, but it is rare comparing to the other underlying causes which lead to gastroesophageal reflux disease. Other presenting symptoms include feeding difficulties. The baby may present, the mom may be present, sometimes they will not present in the first few weeks. It may be after some months even. They can present with feeding difficulties. They are mentioning if the mom is really depending on the cow milk in a very large amount. If she is drinking, the baby will have difficulties from the moment she starts giving baby milk. The baby may have feeding difficulties. They may present with abdominal pain. They may present with vomiting. They can present with dysphagia, failure to thrive. See, failure to thrive is important. If you have an infant with failure to thrive, you can think about cow milk protein. But what we see daily, that the baby is growing well. The baby is gaining in proper ideal. When you put them in growth chart, you will see the baby is very well, doing well. Why should we have to stop the breast milk and consider them as a cow milk protein allergy? If there is weight loss, if there is food impaction, if there is so many things together, you can diagnose them. Eosinophilic gastroenteritis, eosinophilic gastroenteropathy of the stomach and intestine. They may have symptoms of abdominal pain, nausea, vomiting, diarrhea, or weight loss. Other clinical finding of non-IgE mediated reaction, it may be delayed onset beyond 2 hours of ingestion. So we have immediate, or we have more than 2 hours. There are some of them, even it may be after weeks, you will see the symptoms. So the other clinical finding, it is called food protein-induced enterocolytic syndrome. This primarily occurs in an infant. It's present in one of 2 ways. The typical presentation, they may present with severe vomiting and diarrhea within 2 to 4 hours after ingestion of an offending allergen, which cause profound dehydration, lethargy, and sometimes shock. So it will be severe one. The acute phase can be the first manifestation of food protein-induced enterocolitis syndrome, or can occur when the allergen is removed from the diet and then reintroduced. So we will do challenge test. When you remove it, they will improve, and when you reintroduce, they will have the same symptoms again. So chronic exposure to the offending allergen may present with more subtle symptoms such as regurgitation, diarrhea, failure to thrive, and hypoalbuminemia. So food protein-induced, the other presentation, it's called food protein-induced proctitis or proctocolitis. Usually this one presents by 6 months of life or even in later age. They may present with bloody streak diarrhea. There will be mucus in the stool. The stool will be loose and occasionally diarrhea in breastfed or standard formula fed infants who are otherwise well appearing. Okay, so if you have a baby who is more than 6 months of age, infants who is more than 6 months of age and or growing well, developing normally, they are coming to you with blood stain diarrhea. You have to think about it. It could be cow milk protein allergy. Don't tell the mom that you have to stop breastfeeding. First, to tell her if you are in a doubt that can be cow milk protein allergy, ask the mom to eliminate or stop the cow milk in her diet rather than stopping breast milk. So cow milk and soyas are the major causative food that can present with food protein-induced proctitis or proctocolitis. Then we have food protein-induced enteropathy. They present with protracted diarrhea in the first 9 months of life. Within weeks after the introduction of a trigger food, the majority will go to develop failure to thrive. Some present also with malabsorption. They will tell you that my child has loose motion and whatever I am giving the food, it will coming with a stool. So it means the child is not absorbing anything. The other finding, it's called Henner syndrome, or other finding of non-IgE mediated reaction, Henner syndrome, which is food-induced pulmonary hemosiderosis. So pulmonary disease that is caused by food hypersensitivity, primarily to cow's milk. It is mainly Henner syndrome, mainly affected the infants. Symptoms usually include cough, recurrent fever, wheezing, nasal congestion, recurrent otitis media, hemoptysis, failure to thrive, dyspnea, colic, anorexia, vomiting, diarrhea, and hematochezia. So it is a severe, when it is affecting the child or who is more than 9 months may be present in this presentation, it will be severe. You will see lots of things together to diagnose the child as a Henner syndrome, not only by presenting of the one symptoms. The other clinical finding, they can present with infantile colic. It can be, infantile colic can be due to cow milk protein allergy, but before labeling that, this infantile colic due to cow milk protein allergy, you have to think 100 times. The role of that in infantile colic is still controversial. Some moms, they will tell us that I stopped, my child was having infantile colic, I stopped breast milk, and I don't know, it was due to milk I was drinking or due to what, but they told me to stop. And they are not sure. You know, if you tell the mom to stop your milk for a 2 or 3 feeding, and then she will not go back. It is too difficult to put the baby again back to the breast milk. Studies have shown an improvement in colic symptoms after a change to soya-based or hydrolyzed cow milk-based formula or elimination of cow's milk from the diet and worsening of symptoms upon re-challenge in some infants. Nothing will happen if you tell the mom your baby is having infantile, it's severe colic. Normally, all the children, all the infants, in the first 3 months, they will have colic. Whatever you do, they will have colic. This is the normal. This is the nature of human babies. But if it is really severe one and you want to be sure, ask the mom. Most of the mom, they agree. Just to tell her, please eliminate the cow milk protein from your diet. And then give them follow-up, give them, reassure them, and be with them. Don't leave them. Just you give them one word that it may be due to cow milk protein, which you are taking, and then leave them. No, always follow up, follow them, and see, is it really it was true what you are telling or no? They may present with constipation. So cow milk protein allergy intolerance has been suggested as a cause of constipation in infants and children, especially those with refractory chronic constipation. Although this hypothesis also, it is mentioned that can be controversial. So natural history of cow milk protein allergy, the tolerance is achieved by the majority. Non-IgE mediated cow milk protein allergy tends to resolve more quickly than IgA mediated. So non-IgA mediated, they will resolve more faster than IgA mediated cow milk protein allergy. Early report indicated that most children with IgA mediated cow milk protein allergy become tolerant by 3 years of age. So if you diagnose them cow milk protein allergy, it doesn't mean that they will be all their life cow milk protein allergy. No, they outgrow it. So diagnosis based upon history and laboratory testing. History is very important. Whenever you take history, please dig in history. Before deciding, is it due to cow milk protein allergy or something else? Dig in the history and ask more and more investigation. And if you do laboratory tests, because so many doctors, they do a stool test, please, whenever you do a stool test and you found reducing substance positive, it is normal in breastfed infant to have more than 2, 3 plus reducing substance positive in breastfed children. So if it is exclusively breastfed and they have reducing substance positive, don't label them as a cow milk protein allergy. Diagnostic tests for non-IgE mediated manifestations of cow milk protein allergy are limited. The gold standard for diagnosis is a clinician supervised double-blind placebo-controlled oral food challenges. So measurements of cow milk specific IgE can aid in the diagnosis of IgE-mediated cow milk protein allergy and may eliminate the needs for oral food challenges. So diagnosis of IgE-mediated reaction, usually the history is of an immediate reaction consisting of typical allergic symptoms. They may present with immediate skin rash, and they may present with vomiting. It is supported by positive tests for specific IgE antibodies. It's sufficient to establish presumptive diagnosis for suspected IgE-mediated reaction. Then we have to do skin prick test or in vitro test for IgA are usually performed initially. And then higher concentration of cow milk specific IgE and larger skin test will correlate with increased likelihood of a reaction upon ingestion. So they will do tests and they will give the child or the milk and they will see the result. So to diagnose IgE-mediated reaction, when the history and testing are not conclusive, the diagnostic procedures may include elimination of the suspected food for 2 to 8 weeks. Usually we tell the mom, you stop it completely for 3 to 5 days, and then we observe the child. If still the child has same symptoms, then we extend it to 2 to 8 weeks. If the probability is higher, or reintroduction if the probability is lower. If breastfed infants, the dietary elimination includes a maternal exclusion diet, avoiding cow's milk protein. In a formula-fed infant, use either extensively hydrolyzed formula or amino acid-based infant formula. If a minimal to no improvement is noted in a milk avoidance diet and no significant differences are noted with reintroduction, then these are the possibilities that either the food in question is not responsible for symptoms or the diet has not been restricted enough. So always, whenever you find there is no outcome, is not as what you were suspecting, just please take more history and dig in it. The patients may have multiple food allergies and additional foods may be considered suspicious. So diagnosis non-IgE mediated reaction, IgE tests are expected to be negative if the symptoms do not suggest of IgE mediated reaction, such as delayed gastrointestinal reaction and some cases of atopic dermatitis. But atopy patch testing may provide additional information in the case, so it is important to do it. So when you have a child or infant or toddlers, when you want to label them as a cow milk protein allergy, you have to put in your mind, you have to go and sit, take detailed history, do proper physical examination, and then ask for laboratory tests. If it is anaphylaxis or clear immediate type reaction is there, then you have to ask them cow milk protein elimination and test for a specific IgE. Diagnostic elimination, you have early and late reaction. For example, vomiting, atopic eczema, it may occur immediately, it may occur within 1 to 2 weeks, or some of them, they will have gastrointestinal symptoms. It may be extended to 2 to 4 weeks. If there is if you did diagnostic elimination and you found there is no improvement on clinical symptoms, maybe no cow milk protein allergy elimination that needed. If there is improvement of the clinical symptoms, then you have standardized oral challenges with cow milk protein. And if it is negative, again, you have to go back and say no cow milk protein elimination diet. If it is positive, then you have to do therapeutic elimination diet, which I will not tell you about it because our expert dietitian, she will tell us more. So this is nice algorithm. It will tell you if the child is less than 1 year and fed with cow milk formula and mild to moderate symptoms, why to do. Again, it will tell you if it is immediate reaction occur, but you don't have clear history, but the child is presenting with vomiting, acute urticaria, angioedema, so it is severe one. Usually you have to help the child, you have to support the child, and then you will ask the mom to do elimination diet for 2 to 4 weeks, and then you will see the outcome. If it is the improved, then after sometimes some dietitian, they will do oral food challenge test after maybe 6 to 9 months, according to the symptoms, according to the age presented, and so on. And this algorithm, it will show us that if the child is less than 1 year fed with cow milk formula fed and they have severe symptoms, so cow milk protein allergy, you will see in the breastfed infant is very rare, okay? While in cow milk formula, it is more common. So when you are going to decide, this is the cow milk formula, cow milk allergy, first ask detailed history of the feeding. If it is on formula feeding, no problem, you can decide. But to decide it, if the child is on complete, exclusively breast milk, that one you have to think 100 times before saying. But if it is in cow milk formula, no problem. It is, you can decide better than on exclusively breast milk. It is because it is more common in cow milk formula baby than the exclusively breastfed baby. So if you have a child less than 1 year of age with regular cow milk formula and suspected to have severe cow milk protein allergy, then again you have to ask if the child is developing immediate, if the infant or child developing immediate reaction, like a severe one, anaphylactic reaction, laryngeal edema, acute asthma, severe respiratory distress, anaphylaxis, then you have to do again elimination study. But if you have a late reaction, then infant should be referred. Usually when we have severe one, we immediately refer the children. Or it is late reaction, like chronic diarrhea, chronic vomiting, food refusal, poor growth. Poor growth is very, very important in infant. To label the child as a cow milk protein allergy, you have to look at the growth chart. If the growth is normal, don't label them as a cow milk protein allergy. If the child is thriving well, why to label them? You have to look the other causes of vomiting, other causes of diarrhea, other causes of constipation, rather than cow milk protein allergy. So this algorithm, it is for breastfed infant with suspected non-IgE mediated reaction to cow milk protein. So if breastfed infant with suspected reaction to cow milk, atopic dermatitis, vomiting, diarrhea, if they have a stool blood, they are presenting with gastroesophageal reflux, then again you have to clinically evaluate. You have to take family history because it will help you. If they have mild symptoms, you don't do anything. But if they have moderate to severe, again, if they are on exclusive breast milk, you have to stop it from maternal diet cow milk for 2 to 4 weeks. We are generous. Usually we are telling them on 3 to 5 days and see. Because if you tell her 2 to 4 weeks, some of the mom, they are addicted to coffee with milk and something, they will be shocked. So just you tell them 2 to 3 to 5 days. And then if you found it is not they are not improving, then you go further to extend it to 2 to 4 weeks. So this algorithm, if you have suspicious of cow milk protein allergy, then suspicious is mild to moderate cow milk protein allergy. One or more of the following symptoms is present. If it is, for example, gastrointestinal symptoms, they have frequent regurgitation, vomiting, diarrhea, constipation, with or without perineal rash. Yeah, with other finding, cow milk protein allergy, most of the time they will have the specific perianal rash, not only atopic dermatitis on the face, the perianal rash which is present. Also, it will help you to diagnose this is a cow milk protein allergy. They can present with blood in the stool, or they may, if you did not treat them, or if you did not pick that diagnosis, they may present with iron deficiency anemia. They may have the skin manifestation, maybe any skin rashes, or maybe atopic dermatitis. Generally, they may have persistent distress or colic. The normal colic is less than 3 hours per day, less than 3 days per week. If they have more, you have to think about cow milk protein allergy. If the baby is in exclusive breast milk, You continue breast milk, but advise the mom to eliminate the cow milk from her diet. Okay, you can extend it to 4 weeks and then observe. Most of the time they will improve. If you find there is improvement, then you reintroduce gradually cow milk to the maternal diet and then monitor them. And if there is no improvement, resume normal diet in the mother and then consider to do further investigation and diagnosis. If the clinical, you do clinical assessment and clinical finding, you take family history. If there is risk factor, then you suspicious of severe cow milk protein allergy, it will be more and more. So they may present one or more of the following symptoms. They may present all the symptoms together: gastrointestinal problem, failure to thrive. Failure to thrive is one enough to diagnose them. But if the child is thriving, we'll know. Because diarrhea, regurgitation, vomiting, refusal to feed, moderate to large amount of blood in the stool, usually if you did not pick up or you did not treat, it will increase and increase. Even the skin reaction or eczema or rashes, it will be more and more. Then you have to refer to the specific specialist to do further investigation, because not enough by doing the simple investigation, which we do a specific IgE or stool test. So this was my end of my lecture. Many thanks to all of you. If there is any question, anything, maybe by the end of the second lecture, I will be there to help you. Thank you so much.
Thank you very much, Dr. Fatma, for that very extensive and informative presentation. I'm sure we will be getting a few questions by the end. Our next speaker would be Ms. Savita Bijesh, who will be talking about the management of cow milk protein allergy from a dietary perspective. Ms. Savita is a dietitian at Allergy Children's Hospital in Dubai. She has over 8 years of experience providing nutrition assessment for patients and families. She develops nutrition intervention plans for patients and makes recommendations for treatment, which includes diet therapy education and intervention for high-risk cases. She provides bedside and outpatient education and counsels patients and families on nutrition issues, either individual or in a group. Thank you very much, Ms. Savita, for joining us. The floor is all yours. You can start your presentation.
Good evening. Thank you, Ms. Leah, for the good introduction. Hi, you can hear me?
Yes, I can hear you very loud and clear. You can just start sharing your presentation. Yes, just put it on full screen and you're ready to go.
Good evening and welcome every participants to my presentation. Thank you for Emirates Clinical Nutrition Society for giving me an opportunity for this presentation. So today I'll speak about cow's milk protein allergy and then in the nutrition perspective.
Sorry to interrupt. Can you put it on full screen mode so that it's much clearer?
Yes. Yes.
Yes. Go ahead.
Once again, good evening to everybody. I'll just start my presentation. So today we'll discuss about cow's milk protein allergy and the nutrition management. So as we all are familiar with the term CMPA, cow's milk protein allergy, is the most common food allergy in babies. CMPA occurs when the body's immune system abnormally reacts to the protein in the milk of the cows and other animals. It usually occurs in babies younger than 1 year of age. The immune system normally protects our bodies from harmful pathogens like bacteria and viruses. In CMPA, the immune system mistakes the proteins in the cow's milk as a harmful substance that attacks it. This immune system reaction can damage our baby's stomach and intestines. Coming to the epidemiology, general population CMA is more prevalent in infants. The referral populations Cow's milk is the third most common food allergy after peanut and tree nuts, responsible for food-induced anaphylaxis in pediatric and mixed-age populations. Milk is also the third most common food responsible fatal or near-fatal food-induced anaphylactic reactions, that is 8 to 15% of cases. Both formula and breastfed babies can present with the symptoms of CMPA. It's important to accurately diagnose, as Dr. Fatima has mentioned. Most of the CMPA is either overdiagnosis or underdiagnosis. Coming to the prevalence, it affects from 2 to 6% of children, with the highest prevalence during the first year of age. About 50% of children have shown to have CMPA within the first year of life. The prevalence estimates can be influenced by many factors, such as geographical region, source population, high risk, source population, age, participation rate, and limitations of diagnosis. It's thought that 6 to 8% of children aged less than 3 years have a food allergy. Among that, up to 4.9% have cow's milk allergy. Moving on to the next slide. The etiology part, food allergies stem from the host immune system. If an individual has an allergy to milk, the body's immune system responds to a specific protein, triggers an immune response, and attempts to neutralize triggering protein. The next time that the body comes in contact with the protein, the immune response recognizes the protein. It triggers the immune system to mount a response, including the release of histamine and other immune mediators. This release of chemicals causes the signs and symptoms of cow's milk allergy. The pathophysiology, cow's milk contains more than 20 fractions of proteins. The significant allergens belong to the casein and whey protein groups. Most individuals with cow's milk allergies have a sensitivity to both caseins and whey proteins. So immune-mediated adverse food reactions classify it into two major categories, which is IG-mediated and non-IG-mediated, and there is also mixed forms. About 80% of cow's milk proteins are casein-based, and 20% are whey proteins, such as lactalbumin and lactoglobulins. Milk proteins used in processed foods are often labeled as caseinates or whey, but under the new EEC labeling, we'll have to clearly mention the word milk in bold type in the ingredient list. It is unusual to develop milk allergy later in life, but some children will continue to have immediate type severe reactions to small traces into adult life. Most children with cow's milk allergy will get a reactions to goat milk as well, as the proteins are very similar to that of cow's milk. Some infants, about 20 to 30%, may also react to soya, especially if it has been introduced before 6 months of age. Coming to the clinical features, clinical findings of cow's milk allergy frequently appear during the first few months of life, as I have mentioned earlier, often within days or weeks after introduction of cow's milk-based formula into the diet or any weaning food that contains milk, cow's milk. Although symptoms may also occur with exclusively breastfeeding, if the mother's maternal diet is transmitted in breast milk, have sufficient quantities of cow's milk in it. The incidence of CMA is lower in exclusively, however, it is lower in exclusively breastfed infants compared to that of formula-fed or mixed-fed infants, and the clinical reactions in the breastfed group are mostly mild to moderate. It won't be severe. This might be related to the lower levels of CMB in the breast milk compared to that of the cow's milk, and also immunomodulators in the breast milk and the difference in the gut microbiota between breastfed and formula-fed infants may also play a role. Patients with CMPA present with a wide range of IgE and non-IgE mediated clinical syndromes. CMS has a range of clinical manifestations with variable intensity. Moreover, clinical features can differ from immediate to delayed reactions, as this reflects the different pathogenesis. Approximately 60% of CMA are IG mediated, although sometimes estimate change according to the study population and age, and the remaining 40% is divided into non-IG mediated and mixed forms. The latter have different underlying mechanisms, presentations, and implications, which complicate the attempts to estimate the prevalence of CMPA. So next is the IG-mediated reactions. IG-mediated food-triggered reactions generally occur immediately within minutes to hours after ingestion. These reactions are usually rapid in onset and occur when the milk protein, that's the allergen, binds to the milk-specific IG on the surface of mast cells that recognize the protein as harmful. So, occupational and household exposures involving inhalation of cooking or processing vapors containing milk droplets may cause respiratory symptoms. Casual contact by touching can cause localized urticaria as well. Next is mixed IG and non-IG mediated reactions. The mixed reactions may have either humoral or cell-mediated mechanisms and may present with acute or chronic symptoms. Non-IG mediated symptoms can occur 48 hours and up to 1 week after the consumption of cow's milk. So it is a delayed reaction. Non-IG mediated CMA is more difficult to diagnose because the symptoms occur hours to days after the milk consumption. And also the symptoms usually involve GI system and skin, which are very commonly involved in many other conditions in children. There is no specific laboratory test to confirm or exclude the diagnosis. One second, I'm sorry. Next, moving on to the next slide. This is a clinical presentation, how it shows in different IG-mediated and non-IG mediated and mixed forms. These are the clinical symptoms, like onset, IG-mediated, the onset is within immediate to 1 hour. So in that symptoms may be anaphylaxis, urticaria and angioedema, immediate or pharyngeal and gastrointestinal reactions, food-associated exercise-induced anaphylaxis. And the mixed IG and non-IG mediated, it presents with symptoms like eosinophilic gastrointestinal disorders and atopic dermatitis. And the delayed part, which is the non-IG mediated food protein-induced enterocolitis syndrome, food protein-induced proctocolitis, food protein-induced enteropathy, GERD, colic, constipation, Hainer syndrome. These are the presentations seen. Coming to the diagnosis part, a good, reliable history and clinical examination are the cornerstone of the diagnosis. Identification of CMPA can be difficult because the typical symptoms are not that specific to CMPA alone, and instead are the common in and are very common in the symptoms are very common in children, like skin rashes, reflux, colic, and diarrhea. But if left untreated, CMPA can lead to faltering growth, persistent unpleasant symptoms, and in rare instances, it can be life-threatening as well. Furthermore, CMPA is often confused with lactose intolerance, making diagnosis even more difficult. There are some misconceptions from the parental side. I should mention about it. The rate of parental reported CMPA is 4 times higher than that real one in children. So many children are referred for suspected CMPA based on parental perception. Symptoms such as cutaneous eruption, insomnia, persistent nasal obstruction, dermatitis, or positive results to unorthodox investigations. Parents often put their children on unnecessary diet without an adequate medical and dietary supervision. These inappropriate dietary restrictions may provoke nutrition imbalances, especially in the first year of age. An accurate diagnosis of CMPA is very important in order to avoid not only the nutritional risk like rickets, decreased bone mineralization, anemia, poor growth, and hypoalbuminemia, but also that of immediate clinical reactions to or severe chronic gastroenteropathy leading to malabsorption. Now let's see when we can doubt whether it is a cow's milk allergy. A positive atopic family history is a common in children with suspected CMPA. The diagnosis of CMPA is based on the detailed history of the symptoms, skin prick test, and serum specific IgE to cow's milk protein, elimination diet, and oral food challenge. The risk factors are children who have other confirmed food allergies or have comorbidities like eczema are more likely to have CMPA. There is a confusion always between cow's milk allergy and lactose intolerance. So the evidence of confusion between lactose intolerance and milk allergy, which could result in unnecessary diet restriction or avoidable reactions. The management of these conditions is distinctly different, and inappropriate recognition or management may have significant implications for the patients. The currently accepted nomenclature is determined by the mechanism is likely to be producing the symptoms, with cow's milk allergy being immune mediated and lactose intolerance is non-immune mediated. These are the differences. So lactose intolerance results from decreased ability to digest and absorb lactose. And intolerance may occur when lactase, the enzyme required to break lactose into glucose and galactose, is lacking. The malabsorption leads to gastrointestinal side effects, example, bloating, diarrhea, and flatulence. But lactose intolerance is highly unlikely in a child age under 3 years unless they have a history of gastrointestinal infection. It's very rare in infants and children younger than 5 years, including those with CMPA. Breast milk naturally contains a high amount of lactose, which is beneficial for the healthy infant growth and development. It provides energy and supports the absorption of calcium. Lactose also promotes the development of healthy gut microbiota. Therefore, lactose should not be eliminated from the infant's diet unnecessarily. It causes symptoms only in the bowel, but for example, abdominal pain, bloating, flatus, diarrhea, etc. So here's the difference between the lactose intolerance and non-IgE mediated cow's milk allergy. So in the non-IgE mediated cow's milk allergy, the symptoms are gastrointestinal, skin, or respiratory. But in the lactose intolerance, it can be bowel only, for example, pain, flatulence, and diarrhea. And the mechanism in the non-IgE mediated, it is immune reaction to milk protein, but the other one is non-immune mediated. And the test is exclusion of diet, which contains milk protein, symptoms improvement, and the reintroduction. It may take 4 to 6 weeks for the symptoms to improve. In the lactose intolerance, exclusion diet, which is low in lactose, usually improve within 48 hours of exclusion. And the dietary advice in non-IgE mediated, a diet free from cow's milk protein, exclude all cow's milk products, consider tolerance, acquisition and introduction of, for example, extensively baked products after 6 months. And the low lactose intolerance, it is low lactose diet, exclude cow's milk and foods containing cow's milk, although some with low lactose may be tolerated by individuals. If secondary, should resolve by 6 weeks. It is self-limiting but may require lactose-free formula, which can be purchased and should not be prescribed for more 4 to 6 weeks, but not necessarily a hydrolyzed formula. Soya products are not recommended. Now comes the management. So the most straightforward approach in managing any cow's milk protein allergy is complete avoidance of the culprit food. Breastfeeding should always be the first choice, and the second choice is any hypoallergenic formula, which is casein-based or whey-based. In IG-mediated food allergy, remove cow's milk protein completely from the diet. In non-IG mediated, remove cow's milk as well as soya protein due to the cross-reactivity with CMP. And the breastfeeding infants, in breastfed infants, the mother should follow CMP-free diet from 3 to 5 days if it is an immediate reaction, and about 2 to 3 weeks if it is a delayed symptoms. Okay. If no improvement in the symptoms, then it is unlikely to be CMPA, and mother can resume her regular diet, and the child should be further investigated for other causes of symptoms. If the symptoms improve or completely resolve with the modifying maternal diet, reintroduction of dairy products into the mother's diet can be done gradually as long as the baby is tolerating it. But if the symptoms reoccur, then mothers should resume CMP diet supplemented with calcium, 1000 milligram per day, and 400 IU of vitamin D daily. If the symptoms reoccur despite mother's strict diet avoiding CMP, the mother has two options: either restriction of other allergenic food from her diet or switching to therapeutic formula instead of cow's breast milk. If severe symptoms such as severe eczema or enterocolitis with failure to thrive, hyperproteinemia, severe anemia is present in an exclusively breastfed infant, then the infant may be fed therapeutic formula, typically amino acid-based formula, which while the mother is following a strict CMP diet and expressing milk until the child's condition is stable. If the symptoms develop when the formula is introduced to a previously breastfed baby, treatment is ideally exclusive breast milk without any maternal elimination. Why? Because the child was asymptomatic when the infant was drinking only breast milk. Let's move on to the formula feeding. So in the formula feeding, the treatment is to replace the formula with extensively hydrolyzed formula or amino acid-based formula. The common practice is to start with the extensively hydrolyzed formula and use AAF only if the EHF fails, which is in fact a 2008 American Academy of Pediatric recommendation. The duration after switching from EHF to AAF should be considered varies from 2 to 8 weeks. Some experts recommend that AAF should be considered as the first line of treatment in infants with CMPA with severe reactions and severe enteropathy, while others suggest that AAF formula and EHF are both accepted as frontline options in cases of anaphylaxis, eosinophilic enteropathy, failure to thrive, and severe colitis. The European Society of Pediatric Gastroenterology, Hepatology, and Nutrition guidelines recommend that using EHF is most in most of the patients with CMPA because it is more affordable and well tolerated. Use extensively hydrolyzed cow's milk formula as the first choice for the treatment of cow's milk allergy. Extensively hydrolyzed formula contains enzymatically broken down caseins or whey proteins. While not completely hypoallergenic, EHF is tolerated by around more than 90% of infants with CMPA. Due to the remaining protein fragments of EHF, is not recommended as a first choice for those with severe reactions to CMP or those who have sensitive to CMP traces in breast milk. Amino acid-based formula can be recommended, especially for patients with more or severe symptoms. So here in the figure, you can see that the standard formula and the extensively hydrolyzed formula, the proteins are broken down into small peptides in extensively hydrolyzed formula, and it is less likely to cause allergic reactions. In the amino acid-based formula, the amino acid protein is the simplest, completely broken down form. So they are unlikely to bind an immune cells, and therefore does not cause any reactions. Next comes the oral food challenge. Patients who show improvement of symptoms with allergen elimination should be subjected to an oral food challenge after 2 to 4 weeks of CMP-free diet in asymptomatic period to confirm the diagnosis. So the procedure of oral food challenge, CMP either as a formula or pasteurized milk in infants less than 12 months of age, or pasteurized milk in infants greater than 12 months of age, is administered cautiously in the following manner, which is starting with 1 ml, then 3 ml, 10 ml, 30 ml, and 100 ml, given every 30 minutes, which can be done on an outpatient setting. The child should be observed for 2 hours and then sent home with an instructions to continue at least 200 ml of milk a day and stop if there is a reoccurrence of symptoms. The child should be reviewed after 2 weeks to decide whether to continue milk or to stop milk, depending upon the clinical response to the milk introduction. So for those with severe reactions and initial presentation IgE type, the milk challenge is in a different, more grade fashion, which is 0.1 ml, 0.3 ml, 1 ml, 3 ml, 10 ml, 30 ml. So the milk is again less given, which is given in every 30 minutes as an inpatient with all resuscitation facilities, including injection of adrenaline to manage anaphylaxis. A positive reactions to milk introduction confirms the diagnosis of CMPA. If no reactions occur, 200 ml per day of milk is continued for 4 weeks to look for any delayed manifestations. In exclusively breastfed infants, CMPA is mild to moderate in majority of the infants who do not have any anemia or failure to thrive. Breastfeeding is continued till at least 6 months of age, and the mother is advised to avoid bovine milk and all dairy products, including cheese, yogurt, paneer, butter, ghee, as well as milk containing food in her diet. It may take up to 72 hours for the antigens to disappear from the breast milk and for clinical response after withdrawal of milk and milk products. So these are some of the foods which, when the mother is on CMP-free diet, she has to avoid all these foods. I'm not going to read the list. You can just observe. These are the milk containing products which the mother has to avoid during her CMP-free diet. Let's go to the management of IgE-mediated CMPA. When an infant with CMPA presents the classical symptoms of IgE-mediated allergies, such as edema, urticaria, or anaphylaxis, emergency care should be provided as any allergy, and all forms of CMP should be immediately withdrawn. In mild to moderate allergy, EHF is the first choice. Only those who do not respond to the above measures should be switched off to AAF. Those with severe allergy require hospitalization and should be given only amino acid-based formula. OFC, oral food challenge, should be done with caution only in the hospital setting between 12 to 18 months. Those with severe IgE-mediated allergy, oral food challenge should be done only with EHF. The elimination diet should be continued for at least 1 year and the re-evaluation done every 6 months subsequently. The prognosis of infants and children with CMPA is good, as 50% will tolerate CMP by 1 year, and more than 75% by 3 years, and 90% by 6 years of age. Only 5% would continue into adulthood. High total IgE and specific levels correlate with higher age of acquiring tolerance. So now the recommendations for non-IgE mediated CMPA. Non-IgE mediated cow's milk protein allergy, milk specific IgE and skin prick test are not useful for diagnosis. Oral food challenge following a clinical response to elimination diet is mandatory in diagnosis. Those with any gastrointestinal manifestations, sigmoidoscopy and rectal biopsy should be considered. Duration of diagnostic milk protein elimination needed to observe clinical response varies from 3 to 5 days in Ig-mediated allergy and 2 to 4 weeks in others. Unmodified mammalian milk should not be used in infants with proven CMPA, delaying introduction of solid foods or even potentially allergenic foods beyond 4 to 6 months of age has no protective effect in high-risk infants. So this is a diagrammatic representation how to manage a non-Ig-mediated cow's milk protein allergy. If it is mild to moderate, if it is greater than 6 months of age, soy formula can be introduced. Improvement of symptoms. If there is improvement of symptoms, you can continue, and oral food challenge in 3 months. If there is no improvement of symptoms, switch off to EHF. Mild to moderate, which is less than 6 months, only we can use extensively hydrolyzed formula. The improvement of symptoms, continue OFC in 3 months. And if it is severe, only amino acid formula is recommended, and OFC, oral food challenges, after 1 year. If there is no improvement of symptoms, switch to amino acid formula and OFC at 1 year. Next, about other milks, soya milk and other milks. Soya formula should not be recommended before 6 months of age, nor at any age in the presence of GI symptoms, but can be considered as a case by case based on 6 to 12 months of age. Soy is not recommended before 6 months of age due to it containing isoflavones, which may exert a weak estrogenic effect. Also need to avoid soya and soybean products. Babies with CMPA are at a higher risk of having and developing soy allergy. There is also a risk of cross-reactivity. There is up to 14% of Ig-mediated cow's milk allergy react with soya, and there is a 60% of cross-reactivity with non-Ig-mediated cow's milk allergy. Rice protein hydrolysates formula contain proteins not derived from cow's milk. So rice milk is not recommended in those with aged less than 4.5 years due to the arsenic content, and there is a cross reaction between mammalian milks. Goat, sheep, donkey, horse, and other mammals are not indicated for the treatment of CMPA, as they are not nutritionally appropriate for children milk, and products are not suitable for the infants with cow's milk allergy. Juices made of almond, coconut, chestnut, soy, and rice, which are called milks, are not nutritionally adequate for infants and should not be used for the treatment of CMPA. Now there is counseling about the there is some other circumstances that needs to be counseled, that is cross contact and hidden ingredients. Patients must be counseled about accidental exposure to food allergens by cross contact, inadvertent exposure to allergenic food by contamination of safe foods with small amounts of culprit food. This can happen anywhere, where food is served, including the restaurants, using knives and counters contaminated with dairy products, and on shared grills. In addition, breads and pastries may be brushed with cow's milk. And the food labels is to be noticed. Patients must read all food labels. Legislation has been enacted in the United States and many other countries, mandating that ingredient labels on food packages plainly identify the presence of milk protein when it is an intended ingredient. Now the advisory labeling. Some products have advisory labeling such as may contain milk. This type of labeling is not regulated. The risk of allergic reactions to these products is not known, and the frequency of the amount of cow's milk contamination in these products are variable. but have been noted to be high or common in some cases, particularly for dark chocolate products. And the cross-reactivity, most patients with CMPA do not tolerate milk from sheep and goats, and they are unlikely to tolerate milk from deer, ibex, and buffalo as well. However, some patients with CMA may tolerate milk from other mammals such as camels, reindeer, horses, and donkeys. Now, this we have to be considered that there is sometimes food allergens found in non-food items. So consumers with food allergy should be instructed that non-food items may also contain food ingredients such as medications, vaccines, cosmetics, craft supplies, and sports equipments. Labeling laws do not apply for these products. So food allergens that can sometimes, it can be sometimes appeared in unexpected places. So, for example, a young girl with a severe milk allergy experienced a life-threatening anaphylaxis involving cardiac arrest immediately following initial use of pair of boxing gloves. So, natural rubber latex was initially suspected as the allergen source, but the culprit was eventually found to be the casein protein in the padding of the glove, which was aerosolized when the glove was used in punching. So this has to be, those who are on cow's milk allergy, this is also an important part to be taken into consideration. Now the nutritional adequacy of the diet. Since the long-term removal of food allergens from the diet may result in poor growth and development it is critical for the families to meet a dietitian and an allergy physician who are experienced with food allergies. When a food or food group is eliminated, attention must be focused on the potential dietary insufficiencies resulting from these exclusions. A cross-sectional study found that children who received nutritional counseling or consumed infant-older hypogenic formula or a fortified soya beverage had a lower incidence of inadequate calcium and vitamin intake. Most children under 2 years of age, with cow's milk or soy allergy will benefit from hypoallergenic extensively hydrolyzed cow's milk protein or free amino acid based formula which acts as a milk substitute during infancy. Low-fat, low-protein beverages such as almond milk and rice milk are not generally recommended for children under 2 years of age. Case reports have associated the use of these type of beverages with kwashiorkor. When more than one food group is eliminated, nutritional adequacy becomes more of a concern. Vitamin and mineral supplements may also play a critical role in ensuring the adequacy of the nutritional intake. So these are the nutrients present in the milk. So eliminating cow's milk from the diet, it can pose some nutritional as well as the quality of life concerns. Since cow's milk is a major food in cultures and diets, and it's important source of fat and protein in early childhood. So these are some of the nutrients to be replaced on a cow's milk avoidance diet and alternative dietary sources. So you can see the protein sources are meat, fish, poultry, eggs, soy products, peanut, other legumes, tree nut, and seeds. The fat, vegetable oils, margarine, avocado, meats, fish, poultry, peanut, tree nut seeds. And the calcium part, enrich alternative milk beverages from soya, rice, oat, almond, potato, cashew, pea, peanut, etc. And the calcium fortified tofu, calcium fortified juice. Vitamin D can be replaced from foods like enriched alternative milk beverage, fortified margarine, fortified alternative yogurts, fish oil, salmon, and other fatty fish. Vitamin B2, meat, fish, poultry, eggs, enriched alternative milk beverages, and vitamin A, the pantothenic acid, vitamin B5, and the riboflavin. These are the food that is replaced with the other foods. So there is, as I mentioned earlier, there is always a milk reintroduction. So reintroduction of milk after at least 6 months of dairy exclusion or from 1 year of age is recommended. A graded reintroduction is usually better tolerated. The quantity required is depending upon the age and size, with the highest requirement at 4 to 6 months of prior to weaning. So here comes the use of milk ladder. So let's see what is milk ladder. The milk ladder is an evidence-based guideline for the home reintroduction of milk and dairy products into the diets of infants and children with mild to moderate cow's milk allergy. It is a plan to reintroduce milk products gradually and in stages, starting with foods that contain only small amount of well-cooked milk and progressing towards uncooked dairy products and fresh milk. It is called the milk ladder because the completing each 6 steps in the plan is climbing like a rug on a ladder towards being able to be fully tolerate the milk and dairy products. The milk ladder can only be followed by infants and children with mild to moderate allergy, known as non-IG mediated milk allergy. It's not suitable for children with milk allergy that result in severe or immediate type of allergic reactions known as IG mediated milk allergy. Normally, the milk ladder is only started once your child has been on a milk-free diet for at least 6 months and they are completely well with no active eczema or gastrointestinal symptoms. So how long it takes for the milk ladder to complete each step? Most children will start by trying the foods in step 1 itself, but if the child is already having some milk products in their diet, then can be advised to start at a later step on the milk ladder. Each of 6 steps of milk ladder list foods that contain milk and suggest how much the child to eat in a given day. The suggested amounts or guideline decides to a child and smaller, whether it is a smaller amount or larger amount. Child only be able to move to the next step on the milk ladder once they are fully tolerating the milk containing foods in the each step they are on. This means that they have been able to eat the food more than once in quantity suggested on the milk ladder and do not suffer any allergic reactions as a result. Sometimes it can take up to 2 to 3 days for the allergy symptoms to appear after eating the food. Therefore, it is advisable to allow at least 3 days on a step before considering whether the child has to move to the next step in the milk ladder. So, if the child reacts to any food in any part of the milk ladder, what we have to do is stop giving the foods on that step to the child, continue giving the child the foods on any previous steps of the milk ladder that they have successfully introduced to their diet, and this will help to maintain their tolerance. As per the doctor or dietitian, advice on when to retry the next step of the milk ladder. This may be between 3 and 6 months, depending upon how severe the reaction is. So if the child tolerates the step in the milk ladder, then continue to give these foods to the child regularly, as well as foods from previous steps on the milk ladder that they have successfully introduced to their diet. When you can try food suggested on the next step of the milk ladder. Now let's move on to the prevention part. The primary prevention aims to delay the first exposure of infants to cow's milk protein, while the secondary prevention involves avoiding antigen exposure in higher risk ectopic infants. Tertiary prevention is when clinicians advise cow's milk avoidance as a means of treatment after confirmation of the diagnosis. Prevention in exclusively breastfed infants. The best way to prevent CMPA is exclusive breastfeeding for 4 to 6 months of age. The incidence of CMPA is lower in exclusively breastfed infants compared to that of the formula-fed and mixed forms. The reproducible clinical reaction to CMPA are mild to moderate in the majority. A plausible explanation for that is the level of CMP in the breast milk is 100,000 times lower than that in the cow's milk and is in the form of peptides and not as an intact protein. Breast milk also contains proteases and digesting protein. The other protective factors in the breast milk are maternal antibodies and chemokines, which reduce the development of allergy, hormones and growth factors, which potentiate maturation of gut-associated lymphoid tissue. polyunsaturated fatty acids, glycoproteins, oligosaccharides, and microRNAs which exhibit immune function. Let's move on to the next slide. There's no evidence that modification of maternal diet during pregnancy or lactation has any protective effect against allergen at-risk infants. An exclusion diet may cause nutrition deficiencies in the lactating mother and infant. Allergen avoidance should be advised only when the breastfed infants have proven CMPA. There is no evidence to suggest that delaying introduction of solid foods or even potentially allergenic foods beyond age 4 to 6 months offers any protective effect. Supplementary food should be introduced one at a time in small quantities, preferably while the mother is still breastfeeding, but not before the infant is at least 17 weeks of age to prevent other allergies. The prevention infants who are not exclusively breastfed. There is no role for the milk formula with intact protein from other mammals or soy protein in the prevention of allergy. If there is a family history of allergic disease in both parents, there may be some justifications in using partially hydrolyzed formula with whey protein as a starter formula if exclusive breastfeeding is not possible. So let's move on to the later part. Take home messages. CMPA is primarily a disease of infancy with increasing incidence, while manifestations of IG-mediated disease is immediate with multi-system involvement. Non-IG disease is delayed with symptoms related to the GI tract. Clinical response to an elimination diet followed by an oral food challenge is the cornerstone of diagnosis. In children with persistent diarrhea and colitis, sigmoidoscopy and biopsy are useful in diagnosis. Breastfeeding should be continued and all cow's milk protein should be stopped. Most children will outgrow the allergy between 12 and 18 months of age. So these are the references. And that's the end of my presentation. Thank you for all the attendees.
Thank you very much, Ms. Savita, for that wonderful presentation. I would like you all to join us for the question and answers. We will be very happy to answer any questions that you have with Dr. Fatma and Savita as well. If you would both join me in for that now.
Yes.
Okay. Okay, let me see. We've got a few questions coming in. First question for Dr. Fatma. In the early years of the new millennium, even ADA has a concern regarding cow milk protein, those exposed during infant and likelihood of developing diabetes later in life. What is the latest evidence on this subject? Feeding mother's milk or cow's milk during infancy, any difference regarding diabetes development, in other words?
Yes, Dr. Alia, regarding evidence, of course, evidence states that a cow milk protein fed children, they are more prone to diabetes and so many other complications. So for breastfeed, for that, they are encouraging exclusive breastfeeding for 6 months, that it will protect the child from diabetes as well as mother post later on in life.
Okay. Is goat milk or camel milk recommended for babies with CMPA or cow milk protein allergy?
Yeah. Yes. This it is not recommended for CMPA as the proteins that is it's similar to the cow's milk as well. So it is not recommended for CMPA.
Okay. Okay. What is the formula milk brand available in the UAE for such case?
Both extensively hydrolyzed and amino acid based formulas are available, but unfortunately, I'm not able to disclose the names of the brands of the formulas. So it's available in the hospital settings and
Mainly in hospital settings, they are being provided, you mean?
Yes, yes, that's right.
For Dr. Fatma, given that the patch test is not standardized for food allergies, when do you use it and how do you interpret it?
Really, I don't believe in this test at all. For that, I tell everyone, take more history, dig in history, examine the child before doing, this all allergic test is too expensive. Imagine to do food allergy test, they have to pay 4,000 dirham. It doesn't cover insurance. At the end, it will come the result that you don't believe in.
Okay.
So better before doing it, we do sometimes tests by immunology, they will do actually, we refer them. But most of the time, we don't depend on the test. So the most important for us as a pediatrician or I don't know, dietitian, that to take more history, to dig on the history and examine the child. And we have to see so many things. We don't only look at the only presenting symptoms. We will observe a child, a mom, and find the growth chart, developmental, everything. And then we put it together that really it is labeled as a cow milk or no. But really the test, I don't like just to waste the money of the people and then at the end, nothing is coming.
So you believe that it's much better to move on the history and the signs and symptoms of the child and taking the detailed history from the parents themselves?
Yes, Doctora, yes.
Okay. Is soya generally safe for infants below 6 months non-allergic to cow milk, considering the fact that soya is estrogenic? And if so, what are the effects due to phytoestrogen in infants?
Soya formula is no longer recommended as a first-line treatment for CMPA infants, which is less than 6 months of age. The evidence potential risk is to long-term reproductive health in infants fed soya formulas due to the activity of naturally occurring phytoestrogens. And also, especially for the non-IG mediated cow's milk allergy, soya has cross-reactivity which is more than 60%. So that's the reason soya is not recommended below 6 months of age.
Would you like to comment on that, Dr. Fatma, as well?
So I don't like soya because it contains estrogen. Some parents, they are very smart. They read it. I have seen so many moms, they are coming then, they are telling, my baby is a boy. What if I give them my child the soya which contains estrogen? But I don't, whenever there is another option, I go to that before giving the parent choice of soya-based formula.
Do we have to avoid yogurt and cheese for lactose intolerance patients?
Okay.
Yes, go ahead, me answer. Dr. Fatma or Ms. Savita? Lactose intolerant patients?
It depends upon the amount of lactose. The lactose intolerance patients, we are giving the lactose low level. That's not completely avoiding the lactose. So low levels of lactose can be tolerated in depending upon the severity of the lactose, whether it is secondary or primary.
Okay, and how can we assess that in such patients, especially in young patients?
This can be assessed by if there is any gastrointestinal symptoms like mucosal infection or something like this. Depending upon the medical history, we can access that, whether it is a secondary or if there is a rectal bleeding, all these factors are considered.
This is a comment. My suggestion to dietitians to not forget to assess the mother who is breastfeeding her baby with CMPA. Prepare a diet plan that covers all nutritional needs and follow up in the clinic, as she may be a risk for many deficiencies.
Yeah, we ask the mom, whenever we advise her to stop cow milk protein, she has to take supplement of calcium. We advised her. And actually, regarding your first question regarding yogurt and cheese, this yogurt and cheese, it is lactose, but it is processed one. You see the children with milk protein allergy, they are more prone to have problem with fresh milk rather than the other processed one.
So what are your go-to recommendations when we have patients come in with these types of concerns? You know, parents would come in and say that I will be checking for the nutrition deficiencies in this child, etc., etc. So what are your go-to recommendations in such cases?
If the mom is scared that she will develop deficiencies or the baby?
If the mother is scared for the baby to develop, because some, you know, you might have some parents who are overprotective and would think that, no, if I'm doing something wrong, then my child would develop a more severe condition than he is right now.
So if the baby is an exclusive breastfeed, even if the mom she eliminate from her diet cow milk protein, the baby will have the whatever needed from the breast milk. It will be sufficient for the baby, even if you eliminate for the mom diet. But we are scared because of mom, she will eliminate and her feeding is not that much. Her diet, we advise her to take supplement other than source of calcium from other source rather than the milk. Okay, but babies usually they will take, if they are an exclusive breast milk, they're all in requirements. It will be there even if the mom is eliminating from her diet iron, calcium. The only things that we have to supplement the baby, if the baby is an exclusive breast milk, vitamin D, because the rest of the nutrients and mineral the child baby is receiving from the mom. So only we have to support the mom, but baby no, only vitamin D. And
so the main support is for the mother and not for the child himself. Okay. If the mother eats soy formulas anyhow, does it affect a CMA infant?
Yes, it may affect. It may affect, yes, due to the, if it is, especially if it is a non-IG mediated allergy, there is, as I mentioned earlier, there is a cross reactivity of soya, and if it is passed through sufficient quantities through the breast milk, it can be affected the child. So it's not recommended.
So what would be an alternative for the mother instead of the who is lactose intolerant and doesn't need to take soy milk then?
Soya, cow's milk protein free diet as well as soya milk is to be avoided. This has to be avoided, and she can go for, as I mentioned, she can go for other alternative milk like almond milk, rice milk. These are the better options.
Okay, thank you for that. I think we are almost over with our questions. If we have any more questions, is there any point that you would like to discuss or talk about, Dr. Fatma or Ms. Savita? Any points you would like to mention at the end?
I wanted really, if there are pediatrician in our audience has some pediatrician, I want to give them take-home message. Please take care of the children when you are labeling them as a cow milk protein allergy, especially when you have infants in the first 6 months of life. So if this piece of information, they will put in their mind, and not to go directly and tell the mom, your baby have cow milk allergy and you have to stop. They will not tell the mom, you have to stop. The problem, they will tell the mom, you stop the breast milk. They will not tell her, you stop cow milk from your diet. That is the problem. So I wish from tomorrow onward to see less this diagnostic. I feel they are hurry to diagnose the baby as a cow milk protein allergy, and they will advise the mom to stop breast milk, which is crime really. I feel bad. Thank you so much for giving us Dr. Alia, chance. It was very nice.
Thank you very much for joining us. Ms. Savita, do you have anything you would like to comment in the end?
It has to be, as I mentioned in the beginning of the presentations, cow's milk protein allergy should not be either over-diagnosis or under-diagnosis. It has to be properly diagnosed, and so that it will avoid the consequences in future of life.
Okay. Okay, just we have another question that came up, if it's okay. If the mother is taking any soy products and breastfeeding, any risk on estrogenic? I think it's an incomplete.
It is, yeah, sorry.
Yes, continue.
Okay, so if it is like passing sufficient, the maternal diet is having a sufficient amount of soya proteins in her diet, so it can be transferred to the infant, and as well as the there will be if it is passed to the infant, there of course there will be estrogenic effect, and as well as there will be, if it is a non-Ig mediated or Ig mediated is not that much affected, but non-Ig mediated is mostly affected with the cross reactivity.
Okay. Thank you very much for that. Thank you both, Ms. Savita, Dr. Fatma, for joining us. It was a very interesting talk. I'm sure our attendees have learned a lot from you both. Thank you very much for joining us. I'd like to thank our sponsoring company, Nestle, for organizing this webinar. The CMEs will be available 14 days from today. Please fill out the evaluation form that will be sent to your registered email ID. And stay tuned for our upcoming webinar on the 20th of October about diabetes and weight loss management. And we would like to also announce our upcoming Emirates Clinical Nutrition Conference, which will be held from the 27th to the 28th of May 2022. And thank you everyone for joining us. Have a wonderful evening and have a great night. Thank you.